Good evening. It's a great honor for me to have this speech, and I would like to thank the organizing committee for the invitation. So for the next few minutes, we will talk about the anatomy of the tricuspid valve and the echo findings. So starting from the anatomy, we all know that tricuspid valve is the largest valve of the heart, and it has an area of 7 to 9 centimeters square, and the position is anterior and apical. As we may see in this figure, the tricuspid valve is quite challenging, and the tricuspid valve apparatus consists of these 4 parameters: the leaflets, the annulus, the chorda tendinae, and the papillary muscles. We know that the leaflets of the tricuspid valve are thin and mobile and are not prone to calcification as the leaflets of the mitral valve. And as we can see, usually the tricuspid valve has 3 leaflets, the anterior, the septal, and the posterior. We see that the anterior leaflet is the highly mobile leaflet. It is thin and it has a great circumferential area and a great radial length in comparison to the other 2 leaflets. The less mobile leaflet is the septal leaflet, which is attached to the septum, and the smallest leaflet is the posterior leaflet. And we know that the coaptation zone, the area that the leaflets coapt during systole, is around 5 millimeters normally, and the coaptation zone is at the level of the annulus or a little bit more in the right atrium. Besides the coaptation zone, there is also the commissures, the commissure between the anterior and the septal leaflet, which is the anteroseptal commissure that is in close proximity to the aortic valve. We have the septoroposterior commissure, which is close to the coronary sinus, and the anteroposterior commissure, which is close to the anterior papillary muscles. So going to the annulus, we know that the annulus has a 3D configuration, but recently in 2021, we had the new classification of the tricuspid valve leaflets based on the variation. And we know that the type 1 valve with 3 leaflets is the classic form, which is the normal valve. However, we have other types, such as the type 2, where the anterior leaflets are fused, and we have 1 anteroposterior leaflet and 1 septal, type 3A with 2 anterior leaflets, type 3B with 2 posterior leaflets, and other types. Among the variations, we know that the type 3B is the most common. It's about 33% as an incidence. And this classification was derived from this study that included 600 patients. So going to the annulus, we know that the annulus is circular. There is the anterior, the posterior, and the septal annulus, and we know the anatomic landmarks, which is the aortic valve, the coronary sinus, and the anterior papillary muscle. And we know that when the RV dilates or when the annulus dilates because of atrial dilation, the remodeling happens at the anterior and the posterior annulus, whether the septal annulus remains intact. When we go to see the tricuspid valve as a 3D structure, we know that the superior points are the anteroseptal and the posterolateral, whereas the inferior points are the anterolateral and the posteroseptal. What about congenital heart disease? We also have Dr. Jifa in our panel. We know that more than 100 years ago, William Epstein described Epstein anomaly, which includes, of course, tricuspid valve and RV, and we have the classification that was proposed by Carpentier, and it includes the displacement of the septal and posterior leaflets and the atrialization of the right ventricle. And we see that we have mild forms and severe forms, starting from the A to the D type. As we can see here, it's a moderate form, but we can have also extreme forms, like this patient that both septal and posterior leaflets are very high at the right ventricle, reaching the apex of the right ventricle. So this is the congenital heart disease and the Epstein anomaly of the tricuspid valve. If we go to the pathological changes, we know, as we previously said, that we have 3 main categories: the primary TR that involves pathology of the leaflets, and actually recently there was a great focus in the pacemaker-induced TR, which includes 3 subtypes. It's the implantation-related, the lead-related, and the pacing-related. So the implantation-related has to do with injury of the valve during the procedure. Lead-related, it's when we have lead adherence, lead entanglement, so the leaflet may be tether due to the position of the lead, and the pacing related is when we have RV dysfunction due to the pacing, so the RV dilates, and we have dysfunction due to the dilation of the RV because of the pacing. And actually, in this publication of the European Heart Journal in 2023, we know that this is a different category, the lead-induced tricuspid regurgitation, and we have two subtypes, type A that has to do with the lead, and type B, that the lead is incidental finding at the tricuspid valve but is not involved in the tricuspid regurgitation. And this is a 67-year-old female patient with mitral valve prolapse, significant mitral regurgitation, that in this patient we may see also prolapse of the tricuspid valve with moderate regurgitation and eccentric jet towards the septum, and we can see that the jet is mid to end systolic. Going to the functional secondary tricuspid regurgitation, as we said before, we have two great categories. The one is the RV dysfunction, RV dilation, tricuspid annular dilation, where the RV is dilated and the RA is less dilated, whereas in the atrial form, we have a huge right atrium and the RV is less dilated, so we have less tethering of the leaflets and the dysfunction of the RV is less. And we see that actually we have different phenotypes based on the etiology of the secondary ventricular or atrial functional TR, and the differences are the tethering of the leaflets, the RV function and size, as well as the RA function. And here are some cases that involve, first of all, secondary ventricular TR in patients who have left heart disease, a patient with ischemic heart failure, dilated and reduced ejection fraction of the left ventricle. So we have involvement of the RV with significant TR. In the second category, we have primary RV dysfunction due to ARVC. It's an end-stage right heart failure patient with an ICD lead, as you may see, and there is laminar flow, so there is torrential TR in this patient, whereas the LV is functioning well and we have low pulmonary pressures in this patient. And there is another phenotype, as Dr. Jifa said before, when we have patients with pulmonary hypertension, as in major patients, as in this case we have a bidirectional shunt at the PDA, and this patient has pulmonary hypertension and significant TR due to the pulmonary hypertension. So three different phenotypes in ventricular TR. Going to the atrial TR, we see that the RV in these cases is good, is functioning well, and the size is good, whereas we have huge right atrium and biatrial dilation due to chronic atrial fibrillation. Going to the echo of the tricuspid valve, we know that we can have both the transthoracic and TOE images in order to clarify the anatomy. And transthoracic echo, starting from this, can clarify the morphology of the tricuspid valve, grading the TR severity and assessing the RV, as we said previously. So we have several views that we can assess the tricuspid valve and actually see the different cusps in different views tilting the probe. So starting from the parasternal views, we have the RV inflow view and the short axis view at the aortic valve level. We know that if we see the coronary sinus, then we go to this slide. If we see the coronary sinus, then we can clearly be sure that the leaflets that we see are the anterior and the septal. So in this case, we see that we can be sure that this is the anterior and the septal leaflet, whereas if we tilt the probe a little bit backwards, we can be sure that the leaflets that we see are the anterior and the posterior. Going to the short axis view in transthoracic echo, we know that we can see on this level the anterior and the posterior leaflet, whereas the septal leaflet has an apical displacement in most cases with moderate to severe TR. So we can see anterior and posterior leaflets in these views of the short axis aortic valve. If we go further on and tilt the probe towards the mitral valve and the short axis, we can also see the short axis in most cases of the tricuspid valve, showing the septal, anterior and posterior leaflet. And going on to the transthoracic apical views, we know that if we see a four-chamber view, we can be sure about the septal leaflet. However, the other leaflet may be the posterior or the anterior. However, if we do the trick and open the LVOT, we can be sure that this is the anterior leaflet, whereas if we open the coronary sinus, this is the posterior leaflet. And going to the images, we see here, opening the LVOT, we see that this is the septal and the anterior leaflet, whereas in other views, closing the LVOT and opening the coronary sinus, we can be sure that we see the septal and posterior leaflets. The 3D, we can take the images from any side. We can see the tricuspid valve well, and we can well define the atrial, septal, and posterior leaflets based on the site of the aortic valve and of the interventricular septum. So the subcostal view is like the four-chamber view. We see the anterior and septal leaflets, and if we tilt the probe, we can also see the short axis of the tricuspid valve. Concerning the echocardiographic parameters for the severity of the TR, we know that during the last years we have two more categories, massive and torrential TR, and actually these two new categories seem to have a prognostic role in the patients with severe TR, and we have qualitative, semi-quantitative, and quantitative methods, so we can assess the severity of the TR. We talked about the RV function and the size of the RV, so there are indexes that we can rely and estimate the function and the size of the RV that we said a little bit earlier. Going to the TOE images, we know that TOE plays a crucial role, especially in patients that need and go for screening for transcatheter intervention, so we can assess the morphology, grade the severity, as well as assess the eligibility for transcatheter procedures. And we can see that the TOE offers images at different levels, at the mid-esophageal view, deep esophageal view, and transgastric view. Starting from the mid-esophageal view at 0 to 30 degrees, we can see the four-chamber view. At this standard view, we can see the septal and anterior leaflets, as you see here in the figure. However, if we tilt the probe a little bit down to the esophagus, we can assess the posterior and anterior leaflets at this level. Going to the RV inflow view, at the short axis view of the aorta, we can assess both septal, anterior and posterior leaflets. As we can see, if we place our X-plane towards the aorta, we can see the anterior and septal leaflets. However, if we place the X-plane towards the posterior wall, here we will see the posterior and the septal leaflet. So we can assess all three leaflets. If we go a little bit deeper, we can see, like a two-chamber view, the RA and the RV, and assess both septal and posterior leaflets if we go further on down. And going to the transgastric view, which is a very critical view of the tricuspid valve, we can see the short axis of both atrioventricular valves, and we can assess the anterior leaflet towards the aorta, the septal leaflets towards the septum, and the posterior leaflet at the posterior wall. And this is a very good view when doing the transcatheter procedure for deposition of the clip. Also, 3D offers a very valuable image, as we can see. We place the aortic valve at the 150 degrees. This is the anterior, the septal, and the posterior leaflet, so we can have a good orientation and offer guidance. Only two slides about the transcatheter procedures. We know that this has evolved during the last years, as starting with a clip at the position of the mitral valve. We have favorable, feasible, and unfavorable characteristics. Among them, it's the coaptation gap, which should be less than 7 if we consider it a favorable case. More than 8.5, it's an unfavorable case. We know that the lead at the position of the right heart chambers is a limitation concerning the position of the clip. And of course, there are several techniques that we can plan in order to place the clip at the anteroseptal, or going for another strategy, putting the clip between anterior and septal and posterior position. This is a case with a lead at the tricuspid position. The lead has a posterior position at the posterior cusp, and with tilting the probe, we can see and prove that this is actually what we see. You can see here when putting the probe towards the posterior part of the right ventricle, we can very nicely visualize the lead, and also going to the transgastric views, we can see that the lead is towards the posterior leaflet. This is the aorta, anterior, septal, and posterior leaflet. So there are several gaps in knowledge concerning the tricuspid regurgitation. I think that this is the most interesting slide. Gaps concerning the pathophysiology of TR, the disease detection, interventional management, and medical management of this patient. It's very critical to have the patient in good volume. The role of diuretic therapy is very critical in order to assess the regurgitation and the anatomy of the RV and the tricuspid valve. The rhythm control, and also we need to have the patient optimize as for its volume. In conclusion, given the complex anatomy of the tricuspid valve, a comprehensive protocol integrating 2D and 3D, transthoracic and TOE imaging is of paramount role. There is a great variation in the anatomy of the tricuspid valve, so ongoing research efforts are essentially to continually improve the interventional techniques and integrate them with other advanced imaging methods. Thank you.
Thank you, Dr. Drakopoulou. A very comprehensive talk. You have presented all the strengths of 2D and 3D transthoracic and transesophageal echo. We are happy to use in everyday clinical practice the 3D echo. Do you think that we need the other cardiovascular imaging modalities in order to evaluate the anatomical morphological data of tricuspid valve, or we are okay?
I think in everyday clinical practice, we can assess by echo very well the tricuspid valve, and I will insist on assessing also the RV function, LV function, and actually understanding the pathophysiology of the tricuspid regurgitation. I don't believe that in everyday clinical practice we need more imaging, but in patients that are scheduled or are for discussion for further interventional therapy or even surgery, maybe we need something more, but this is individualized. Maybe we need cardiac CT or even MRI in congenital patients for sure. But overall, I think that in everyday clinical practice, the transthoracic echo and transesophageal is good, except for individualization when we have to discuss for intervention or surgery.
Thank you very much for the presentation. Even if the tricuspid valve is anterior, and as you know, the transesophageal is very difficult to image. You had very good images for the transesophageal cases. I want to ask you, usually we have 3 leaflets, anterior, posterior, and septal, but there is also a classification, the new that you showed. In your practice, have you seen patients with more than 3 leaflets? Or maybe, are you taking into account into the anatomy the anterior papillary muscle in order to define which leaflets are you describing?
Yes. Actually, when we assess a patient, we are not so focused on the tricuspid valve concerning the anatomy. So I don't think that we check with the transthoracic echo in detail the number of leaflets. It's a little bit hard. In transesophageal echo, we can distinguish the 3 leaflets or more, and we use the anterior papillary muscle for distinguishing the anterior from the septal leaflet, so it's like a guiding structure. But I think with the transthoracic echo, it's not like we focus on the number of the leaflets, because I don't think that it's of clinical importance. I think this counts when we need to do a procedure and we need to schedule the plan.
Thank you very much.
Dr. Samarkati, please.
Thank you, Dr. Drakopoulou, for the nice presentation. I just have a couple of questions for you. First question is, do you depend a lot on multiplanar imaging during doing a TR case or like edge-to-edge repair, and do you think it will help, or usually mid-esophageal going back and forward and explain from the RV inflow is more reliable? And second question, have you encountered using ICE or intracardiac echo 3D in your practice, and do you think it's the new tool coming around the corner, or still there is a big room for transesophageal echo to stay in the game?
Thank you for the questions. We usually use the X-plane or the multi-D, depending on the echo machine we have. And I think it's very good to see in two planes the tricuspid valve, because we can be sure in which cusp we are, and it's very good. I prefer both the multiplane or even the 3D zoom when we go transgastric, so it's very good to have the 3D imaging. I think it's also for the mitral valve, but also for the tricuspid, it's very good, and we need to do it in TOE. Concerning the eyes, we only do TOE in our cath lab with Professor Agheli. We're in the first department of cardiology in Athens University. So we don't have a big experience with eyes, but I think that it's a promising technology. Maybe the next years, and if we put it in clinical practice, it can offer, I think, some advantages, because we don't have to incubate the patient. And it's the limitation is that it's invasive. I mean, we need to put an extra catheter, so there is a limitation, but of course the patient does not need intubation, so this is a big advantage, I think. But our experience is limited. We usually use the TOE probe.
Very nice talk, I enjoyed it really. Just 2 points you already mentioned, I think it's worth pointing again, is that defining the mechanism defines prognosis, and we know that the R related to right ventricular dilation carries worse prognosis than RA enlargement and DR. And the same occurs with lead TR. If the lead causes TR, then the prognosis is worse, because it's going to get worse throughout the years, and needs more close follow-up, where if it existed before, then things are better. That's the one thing. And the second thing is obviously very crucial to define the morphology of the valve for the to decide which intervention is better for the patient.
Excellent talk. Congratulations. To the point that Dr. Sondos is making regarding multiplannar reconstructions, I think this is the way to go in the future, especially now that we have the transcatheter tricuspid valves. We use multiplannar reconstructions heavily, and that also helps expedite the procedure. And I think also for TEER, it's a very good tool to use because going into the stomach and back into the esophagus all the time can create injury to the patient. So for the sake of efficiency, we use multiplannar reconstructions a lot for edge-to-edge repairs as well.
Yeah, that's a good comment. And I also wanted to extract from congenital patients that sometimes in our everyday practice, the subcostal views might give us, in some patients, a very good idea of the tricuspid valve anatomy. Not all adults obviously have clear subcostal views, but as you are there doing the IVC and see what the IVC is doing on inspiration, etc., if you do the subcostal short axis, you will get a view like the transgastric view that you showed very beautifully. And you may have this slim patient that has really very nice pictures. And when I do it in adults, they ask me, what are you looking in my abdomen? And they are not used to having this examination and this subcostal view. So it may be helpful. Let's try it in our everyday practice for the anatomy, but congratulations for your talk.
Thank you. So we continue with the last talk. Dr. Tsoumani.